By 2017, opioids caused more deaths per year than the HIV/AIDS epidemic did at its peak in the 1990s and caused more deaths from car crashes or guns. Further, the crisis seems to be particularly intense in Ohio, West Virginia, Massachusetts, and New Hampshire. Why is this the case? What are the causes of these soaring statistics, and what can be done to alleviate the opioid crisis? Hello, everyone, and welcome to the Beyond Bias podcast, the open-minded perspective. I'm your host, Dr. Craig Albert, Associate Professor of Political Science at Augusta University. Today, we are talking to Dr. Neil MacKinnon, Provost of Augusta University. A pharmacist, Provost MacKinnon has practiced in both the community and hospital settings. In 2010, he co-authored a national best-selling book in Canada called Take as Directed. His fourth book, which we're talking about today a little bit, on the opioid crisis, will be published in late 2021. Welcome, Dr. MacKinnon.
All right. Thanks, Dr. Albert.
Let's get right into it. Can you briefly describe the crisis? Why is there an opioid crisis? I can't say the word. So why is there an opioid crisis? And what is it exactly? What do we mean? I've heard some call it an opioid endemic or pandemic itself. Like, what does all that mean?
Yeah, and if you think about it, right now with COVID-19, most folks are aware that's considered a public health crisis, right? Because it really kind of impacts our everything we kind of do as a society. So just before kind of COVID-19, we had another public health crisis in this country, which is continuing today, again, which is this opioid crisis. And, opioids themselves aren't necessarily good or bad. Most of them were developed to treat pain. If you think of, a lot of individuals that have significant pain, whether it's cancer, you have wisdom teeth pulled by, a dentist. So there's a need for these drugs. The challenge is that in many ways they were kind of misprescribed over a number of years, potentially even misrepresented by pharmaceutical companies. Mm-hmm. And then synthetic opioids have also been developed. And some of those we can explore a little bit more in this podcast, but have really caused challenges as well. And fentanyl is another one of those drugs. So it's a combination. And in many cases, they're prescribed legally, but they've just been kind of overprescribed. And again, they're highly addictive. That's the other thing, right? So
is the crisis more on people who are overusing or misusing legally? I mean, they're prescribed to them, or is it more of people on the streets getting them, or friends trading pills or something like that? Like, where's the worst part of this?
And actually how you frame this, to be honest, it's a bit about both. So it's not, so certainly, drug dealers use opioids just like they would use, many other, because they're highly addictive, right? So the idea is you get folks addicted and then they come to you and you can sell them. And that's certainly been part of the process. But part of it would be, again, someone who maybe goes to the dentist, gets their wisdom teeth pulled. The dentist prescribes, opioids. They go to the pharmacy, they get it filled, they start taking it, and essentially then they become addicted. Could be other things like, someone has chronic back pain. Again, they've tried everything. They go to their doctor and they become chronically addicted to that. So it really touches every aspect of society, every demographic, people that receive those drugs legally through a prescription or illegally, through a drug dealer.
Are there any type of main indicators of potential abuse or addiction? Is it if you're, drink heavily or something, you might be more prone to be addicted to pills once you start taking them? Or is it a subset onto itself with the causal variables for addiction for opioids?
Yeah, that's a great question. So a lot of research has just gone into, why is it that some individuals become more addicted, right? And you kind of think of almost anything in life, whether it's, gambling, right? Or anything, why is it that some people become more addicted? And clearly there is a genetic factor. It's certainly, again, not the entire, it doesn't explain 100%, but that is part of it. And, I think, just in the last maybe 2 decades, a lot more understanding of what are those factors. And again, how can we kind of proactively watch for those too? You can kind of think of it, if you were a physician, even, again, prescribing a pain medication, wouldn't it be good to know if this patient A has, maybe a 40% chance of becoming addicted, patient B has a 4% chance. I mean, that might influence what you decide to prescribe as well.
So I have chronic back pain.
Yeah.
So I've been going to a chiropractor. So that's been, for some reason, the best thing for me. But when I was going through the pain management phase, if I used them too much, I couldn't get them. The pharmacy would be like, no, we're not refilling this. Like, you went through that first 24 pills, too quickly. 4 days later, I was like, whatever, I don't care anymore. And I just didn't go back to refill it. I mean, it seems like there are mechanisms in place to stop people from overuse or using too many at one time.
Yeah, exactly. And what you've described is called a prescription drug monitoring program. So all 50 states have them. They've really, this is the kind of scary part, really only, many states have only implemented those in the last few years. And so, I moved here in December from Ohio. And so in Ohio, it was really only around 2014-15 when they implemented the program there. So before then, what you would have would be people going to sometimes multiple physicians. We call that, double doctoring, or even pill mills, where basically physicians, all they're doing all day is writing prescriptions for pain medications. There was often they do a kickback program with pharmacies, and they were kind of in on it together. And we call those pill mills. So a lot of those were broken up in states like Ohio, like Florida. And so these programs have been implemented at the state level, so different states, where essentially it essentially makes physicians go through a number of hoops before they can prescribe, and would have quantity limits as well. So just like you've experienced. And so the idea is that then cuts down on, again, double doctoring, people going to physician A, getting a prescription, then going to physician B, because it's a centralized database in that state. And so it really, that's been one of the more effective mechanisms for reducing, at least the prescription opioids as well.
The nation has had, and especially in political science, we talk about federal powers versus state powers, and where's the proper authority for different resources? Does it rest, with the president or Congress, or with the state? And we talked about this, about the coronavirus pandemic. Is it proper for the federal government to handle this, or the states? Do you think there's the same type of argument or debate going on for this crisis? Like, should the national government just step in and say, no, there's going to be a database nationwide, a clearinghouse where we keep track of all this, or is it better handled by the state?
Yeah, it's, again, that's probably another answer. It's a bit of both, because clearly, for example, the FDA approves new medications. So you could say, well, maybe part of it's their fault. Are they approving medications that really we don't have the evidence that we really need to look at? Certainly the federal, there is some federal jurisdiction, but certainly in this case, the practice for physicians or pharmacists or nurses, those are at the state level. So there's a state board that governs those professions. And so in many cases, it's really state governments that have become more active, because they're kind of, for example, in that case, controlling what a physician can or cannot prescribe. That's done at the state level. I think, the idea of having a national database, though, would certainly make a lot of sense. Some countries have done that. I'm originally from Canada. So, for example, medication errors, another topic I'm interested in. Canada has a centralized database for that, so it really helps across the whole country. The United States does not have that. And so I think in some cases that, almost going back to, political science, that balance of powers between what the federal government can do and the state government, sometimes in the United States, it's a good thing with those division of powers. In this case, I think a central nationalized database and standardized policies across states would make a lot of sense.
Do you have any information on, or data, and I know this is still relatively new from the pandemic, but on how the lockdowns and the pandemic affected the opioid crisis? Any sense of...
Yeah, and certainly there is some evidence that it has exacerbated the problem. And I would say, just for example, if you look at the volume of prescription opioids that have been prescribed, because of things like we talked about, these prescription drug monitoring programs, we have seen a decrease since around 2018. And then this past year kind of threw a wrench into that. We also saw a decrease in opioid overdose deaths. Generally compared to 2017. So a decrease in 2018, a decrease in 2019. Some states have seen a spike again in 2020. And if you think about it, the fact that, this certainly the crisis has exacerbated a lot of mental health issues, and it's, to be honest, like some folks that maybe are, at home, they're bored, right? Just things like that have contributed to it. So I think, as we look back, we're going to learn a lot from the COVID crisis and how it's had unintended effects in other areas. And I think you're exactly right. The opioid crisis is one area where, unfortunately, it's had a negative impact.
I ask this a lot of my guests. How do you separate studying something and researching something that's pretty gut-wrenching, when the hundreds of thousands of deaths and, it can tear families apart, just addiction overall. How do you balance your research from you and stay mentally, capable and healthy yourself when you're doing all this kind of research into the effects of this?
Yeah, and I think it's very easy to almost get sucked into that negativity. And I would say it's even a greater problem for those frontline health professionals. And I'll just share something with you. At the University of Cincinnati at UC Health, where I was previously, I co-chaired the opioid task force. And I still remember this was August 2019. We were having someone from the governor's office tour our emergency department to look at what we were doing. And just before she arrived, I got there a few minutes early, and I was speaking with the emergency room physician who was part of our task force. And we were just kind of making small chat. And he looked tired. He had just worked a night shift. And he confided in me, that night they had 13 opioid overdose deaths, or not deaths, but cases that came into the emergency department. So if you think about that, a night shift, and just constantly you're putting out fires and trying to help people, and, in many cases administer dose after dose of Narcan, naloxone, which is the main medication given in overdose cases, it can be pretty disheartening. So you're right. So certainly there is that challenge. I think on the positive side, though, there are a lot of neat strategies that can help, and we have made, it certainly is a crisis that we have made progress. And so on a more positive side, one other thing I did in the city of Cincinnati, their fire and police departments have come together and formed what they call quick response teams, in that they show up at a residence where an overdose happened. So they show up unannounced 2 to 3 days later, and basically saying, did they get into rehab? How are they doing? And so one morning I did a drive along. I was part of the police and fire departments. They were showing up unannounced. And you could see how some folks really appreciated the follow-up and showing that their care, and, kind of maybe viewing their police department in a different light than
community
they
engagement.
Would. Exactly.
That is awesome.
Yeah. So those are quick response teams. There's a few cities, a few in Rhode Island and Ohio and others that have started this maybe about 3-4 years ago, and starting to spread across the country. So you see some positive come out of that. With pain control in general, one challenge that's come out of this is, have we gone too far on the other continuum? People that rightly, are in severe pain, need medication. So whether it's, chronic back pain or whatever, is it now so difficult where a lot of physicians are saying, I'm just not even going to prescribe this because I'm going to get audited by my state? Because again, these are effective medications that for most people, they're not going to become addicted. So getting that sweet spot is challenging too. So I think there's been a little bit of pushback. Have we gone maybe too far? And now are there people suffering needlessly?
Because the doctor is afraid of getting brought up or investigated.
Yeah.
That's a tough issue. I mean, that's a hard situation to be in as a doctor. I recently ran into an old friend, and this is last week. I hadn't seen him in a decade. He said the whole world united against COVID-19, but you couldn't pay a politician to do something about the opioid crisis. And it really just I was speechless. I was breathless, because I was like, I haven't seen the news talk about this. It was right before COVID. That's all you saw in the news a lot about. I wonder if there are comparisons between the two, or in just your opinion, why something was done so quickly about COVID-19, but so little legislative about opioids. Is there something in your industry that...
Yeah, that's a fantastic question. I hadn't really kind of thought about that before. One area of interest of mine in research in general, what I teach as well, is health policy. And I think, unfortunately, we have a number of things, this kind of littered history of kind of bad things we're doing in society that really require kind of new approaches to health policy, and it almost takes a crisis till we get there. And I think in fairness, I think states and federal government have stepped up. So under President Obama's administration, did some important things that were continued actually under President Trump, and the Surgeon General Jerome Adams, certainly made it a priority when he was Surgeon General until very recently. The opioid crisis was a declared national emergency. But I think the challenge is there's not one simple thing. So it's not like developing a vaccine, right? And then hopefully that will eradicate COVID. So the opioids, decreasing prescribing is part of it. Getting better rehabilitation, better preventive strategies, maybe better medications to combat overdoses as well. So, but it's not kind of, sometimes politicians like one simple solution that they can tote and say, I've done this. The opioid thing's messy. It's messy. And so I think that's part of it. What's interesting, though, is that the states certainly have become very engaged in lawsuits against the pharmaceutical companies. Michael Moore, not the filmmaker, but a different Michael Moore, who was the attorney who led against the tobacco industry, against British Petroleum with the oil spill in the Gulf of Mexico. He's been working with a number of attorney generals and kind of leading a lot of lawsuits against drug companies, drug wholesalers, and others. So I think the states, when they see some money perhaps involved, they've been very engaged in.
There was like just recently a record payout for the opioid, right?
There's been kind of record after
200,
record.
300 million or something.
So, Purdue Pharma and some of the drug companies, but actually, the real money, and this is where I think a lot of it is headed, is just the wholesale companies like McKesson. What was their role? Because they knew which pharmacies were filling which orders for medications. They knew which physicians were prescribing. So, why weren't they doing anything about it? So it's also, again, what's the role of the physicians? What's the role of pharmacists, of drug companies, of wholesalers? It's a pretty wide net that you can cast as far as folks that maybe played a role in this.
So there is some culpability to pharmacy companies, to doctors prescribing it. So it's not all on the person that gets addicted. Like there was, in some instances, people overprescribing purposely or
Clearly, yeah. There were definite pill mills that were happening in states like Ohio, like Florida, where federal officials came in, and there's been prosecutions, both pharmacists and physicians that have lost their licenses. And clearly, if you look at the volume of opioids, it was clearly just writing one prescription after another and filling it. So
I see the pharmacies or the pharmaceutical companies profit, right? So they obviously want to push it. What's the prescribing doctor get out of this when they overprescribe?
Well, essentially, revenue from that patient visit, so they can charge for that patient visit,
wow.
And then of course the pharmacy, the profit from filling the prescription. So clearly, and again, this is certainly a minority of physicians, a minority of pharmacists. I'm not, I'm a pharmacist myself, so and clearly, I think most health professionals have good intentions, but at the same time, clearly that was part of the problem. I think the pharmaceutical industry is interesting. There's a study published in JAMA, which is one of the top two medical journals in the country 2 years ago, that found that areas of the country that there was more money spent by pharmaceutical companies on advertising opioids, those same areas had higher rates of prescribing and then also problems with addiction too. So clearly there was some, there's some controversy over, how forthright were drug companies on the addictive properties of these drugs. There's some of these drugs are quite old, and they were kind of advertised in the 50s and 60s as being kind of cures for everything, when really there should have been more warning about the addictive properties.
I mean, it sounds almost akin to the tobacco.
Right. I think that's probably why Michael Moore, got hired by some of the attorney generals to represent that. So I think that's part of it. I think the other development, because I don't want to put all the blame on kind of drug companies and physicians and pharmacists and others and drug wholesalers, is the development of synthetic opioids. And so
what's that mean?
So those would be like, they would be developed, it could be essentially almost like, if you think like a moonshine, somebody who's making alcohol kind of in their back lab, these would be medications that are made in a someone's own. It doesn't take a whole lot to make these, and then certainly one drug in particular, fentanyl. Fentanyl is a drug that's very potent, more potent than morphine or heroin. Very fine, white powder. You don't need a whole lot, so it's perfect if you're a drug dealer to mix that, to cut it, with other medications, because it's highly addictive as well. So you have customers coming back for that. Unfortunately, and what's kind of scary as well is that. And I remember we had one of the speakers when I was at University of Cincinnati in my college was a local police chief, Tom Seiden, and he was saying, I'm not going to tell you, but he would say, I can order fentanyl from China. I know the websites. I can have it shipped to me in about a week, and it goes through customs and everything. It's undetected. And so I think that's the other challenge. Some of this is also coming in from countries like China, that because it's such a small quantity, right? We're not talking about, hiding big bushels of drugs. It's such a small quantity is needed that you could then cut with other medications.
Wow, that's terrifying.
Yeah, it really is. Yeah, I mean,
if you feel comfortable, can you tell us how and why you got into studying this? What led you to your particular research and teaching interest?
Yeah. Well, again, certainly I'm a pharmacist and also a PhD trained pharmacist. So my whole career have been involved in in research. And, I think for me personally, I think was living in Ohio. You kind of mentioned, Craig, at the start of the podcast, some of the states have been more, unfortunately, impacted by the crisis. Ohio is one of those. In fact, the number one county for a number of years in the entire country as far as incidents of opioid overdose deaths was Montgomery County, which is the county where the city of Dayton in Ohio is. That was about 50 minutes north of Cincinnati, so kind of in our same metropolitan area. Morgues were full in Dayton. You couldn't fit anyone else in there because of the number of deaths and just the impact. So when I was living in Ohio, kind of seeing the impact of this crisis, I kind of felt, well, I'm a healthcare researcher, I'm a pharmacist. This is something I should be involved in. It was interesting. I ended up getting grants from the state really to evaluate how effective their strategies were. So we were kind of independent academic kind of third party looking at, these things like prescription drug monitoring programs, like prescribing guidelines, like making naloxone available at pharmacies without a prescription. Did they actually work? And so it was kind of was neat to kind of be involved in that. The cool thing of the role of academia and universities like AU is that we can play a role in helping with the problems that our communities are facing. And so I think I think even this podcast, right? So you're fostering discussion on these important topics. And so to me, especially public research universities, we have a special calling in life, and we need to be engaged in problems that our communities are facing.
So you directly had an impact on policy discussions on this in Ohio. I mean, that's pretty amazing.
Yeah. I mean,
that's awesome.
And I think that's like whenever it doesn't happen very often in your career as a researcher, but when those moments happen, it was kind of cool. And then part of my research team at Cincinnati was involving a geographer, and we were looking at the spread of the opioid crisis. So a year ago, in March 2020, when COVID started, this geographer and I started kind of talking like, could we take the same techniques that we're using to look at the spread of the opioid crisis and apply them to the spread of COVID? And we did. And so we ended up, publishing that, doing some health policy briefs for the governor's office in Ohio. And it was this cool moment, Craig, where it was a Wednesday. We looked at a brief looking at kind of urban-rural differences in Ohio. We sent it to the medical director in the Ohio Department of Health on a Wednesday afternoon. The next day, on a Thursday, the governor had a press conference, and he had our map behind him talking about it. And I'm thinking, like, oh my goodness, that is like the ultimate, heaven or nirvana for a health policy researcher is, to have that. And again, I think that's the value of public research universities like AU, and we've seen that, of course, predates me here, but the impact that AU has had on COVID-19.
Yeah, that sounds like you were doing medical intelligence surveillance.
So.
That's something that the Intelligence and Security Studies is trying to team up with right now with operational medicine downtown, is to create some type of medical intelligence surveillance of infectious disease, of crises that we can really investigate and map out using Intel fusion centers. That
makes a lot of sense. No, I'm really, really pleased to hear that, Craig. And I think, there's so much potential with that kind of interdisciplinary research.
I'm such a dork. This stuff excites me so much. I'm like, we can do this and this and this. I mean, we're talking about serious issues, but there's so much that we can do. I tell my students, anytime they write a paper, they can't have a fluffy conclusion. Their conclusion has to be policy relevant. It has to have implications and bring it back to the real world. Because, often people accuse academics of just being, ivory tower elitist or something. But I think if you get into it for the right reasons, and I got into it to be I saw things and I went, why does war happen? In my area of expertise, how do I stop it? It's exciting to talk to somebody who's had that kind of real experience.
Well, and I share the same geekiness, nerdiness that you do with policy and the impact. And I think sometimes what's more fascinating are the unattended effects. And so I remember early on as a graduate student, there was a study published in the New England Journal of Medicine that looked at the state of New Hampshire, and they imposed, they thought they were, Medicaid patients were prescribed too many drugs. And that, there's probably some truth behind that. And so the state put a cap saying, you can't get more than X number per month. Well, what happened is, yes, that reduced the number of prescriptions, but it had this kind of water balloon effect. You squeeze down on one side and it pops out in the other. And what was happening is there were more emergency department visits, more hospitalizations. And to me, it always kind of stuck out. There's always these unattended effects of policy, right? And just like we talked about with the opioid crisis, it's good intentions to try to reduce the number of probably of opioids that are prescribed, but the unattended is, have we gone too far? Are there people now with pain that just can't get the drugs they need?
I mean, it sounds like this health policy and the pharmacy professionals fit into the liberal arts and studying the human condition.
You might be onto something there as well, right? So
all the focus is on STEM, but I think we need to focus on the human side as well. And for cyber operations, for health policy, this human condition is important, and we often forget about that in the classroom and just in public in general.
Yeah, I think and certainly when you you hear the stats of the opioid crisis, it's concerning. But when you think of individual lives, right, that have been impacted by this, that's where you're right. It really starts to be real. And it was interesting, actually. One of our physicians who was part of this task force I chaired in Cincinnati, who was very open with this. He was an emergency room physician who had opioid addiction at one point in his career, and so you think about how he overcame that, and just kind of the value that would bring, the richness to his interactions as he's helping patients, with this addiction as well.
Well, here's the $1 million question, right? How can we help the situation? What can we as members of society do to help solve the opioid crisis specifically, but maybe with, issues with addiction overall? How can we be better humans at helping this issue?
Yeah, I'll kind of answer it maybe in a broad context. Certainly one thing that COVID-19 has exposed is that in the United States, we do a fantastic job of kind of intense medical intervention. So things like ventilators, hospitalizations. I mean, we're world leaders, right? So if we're world leaders sick, where do they go? The Mayo Clinic, the Cleveland Clinic,
Right.
Places like that. But one area where we're, I think, far behind other Western developed countries is kind of a public health infrastructure, right? And if you think of, COVID-19 as an example, and do not want to go into politics at all, but certainly, again, the development of the vaccine, a huge, and if you look at our vaccination rates, we're kicking it out of the ballpark. But as far as the infection rates at the early phase, not so good compared to many other Western developed countries. And I think, to me, the opioid crisis is another thing where that crisis in part was really made worse because we don't have great rehabilitation facilities and prevention strategies and education. Again, if somebody certainly has an overdose and they show up in an emergency department, they're going to get great care, right? Whether that's AU Health or another hospital, but it's that prevention. Could we have prevented that overdose to begin with? And then once they get that treatment, in that acute event, then what? Are they going to show up in the emergency department again? And I think that's what's really frustrating too, and often contributes to burnout with health professionals, is that they see the same patients again and again and again. So that, again, that public health kind of system behind the scenes, again, that we really could have used in COVID-19, we could have used with the opioid crisis. We're still lacking in that in the country. And again, maybe that's the role of federal funding, is to provide, we have the CDC, of course, we're blessed to have them right here in Georgia. So what's the role of the federal government for public health funding?
Yeah, and it's, I've recently published a COVID piece examining whether or not COVID is a threat to national security. Doing the research, I was astonished at how the United States is so far behind at viewing health security as an actual security apparatus, as something that can threaten the United States economically. How many people have to die of something before it becomes a threat to our country? And certainly, we argue that COVID is the perfect example of this type of threat, but a lot of these spontaneous new discovered infectious diseases fall under that. And we're discovering like one every year at this point,
right.
Something that's dramatically horrible.
Yeah, right.
But it seems to be such a topic that politicians don't want to touch because it's not WMD, it's not terrorism, it's not warfare. So it's hard to wrap people's mind around that it's an actual, at least economic threat if it's not a person threat. A human security threat is what we call it in political science.
Yeah, I think you're onto something with that as well. And if you think, I think part of it is again, there's maybe not one quick intervention that solves all these health problems. And in many ways, of course, the U.S. is the outlier of not having. And again, I'm not necessarily advocating that, but it's been interesting. Again, we don't have a central kind of government kind of funded insurance system. And again, it's been interesting, as listeners can tell, as you introduced, I'm originally from Canada. I'm a dual citizen. So kind of just as a health professional, both my wife and are health professionals. We've worked in both countries, and just seeing, it's too bad we can't take parts maybe of the Canadian system where, for example, if a Canadian loses their job, they don't have to worry about losing their insurance. Everything is covered in the hospital, emergency departments. They have that public health infrastructure. After the SARS outbreak about a decade ago, they really, for example, Canada really invested in that. And you've seen that with the COVID-19 numbers. Their infection rates have been ridiculously low. But then, of course, in the U.S., we have this, the innovation, right? And again, the access to care, which is really important as well. And so that's the challenge sometimes in Canada. I think of my own parents that still live there. It's often they can't even access a primary care physician, and they go to the emergency department for that kind of care, which we don't want. Viewing health as a security risk, security threat is right on. It definitely should be considered in that way.
This has been awesome. I don't want to hold you too long. Thank you so much for being on the podcast. Everybody, listeners, viewers, make sure to follow us on social media. Like us, subscribe, share, comment, email. We are at beyond_bias_podcast on the gram. Our YouTube channel is Beyond Bias Podcast Channel. Feel free to email us suggestions, comments, questions, anything at all, recipes at beyondbiaspodcast@gmail.com. And of course, follow me, your host, at Dr. Craig D. Albert on all your typical social media outlets. Dr. MacKinnon, is there a way for listeners to follow or keep up with you and what you're doing?
Yeah, certainly. As the provost at AU, my Twitter and Instagram handle is AUG_provost, AUG_provost. And since we're, again, a public research university, it's always great to hear from the public for sure.
That's awesome. Thanks so much for taking time out of your busy day to being here and to talking with me. I know everybody's going to love this. And as always, we're going to end with a quote from Alexis de Tocqueville, the eminent social and political philosopher. And I tried to pick one to fit into today. Quote, "Everybody feels the evil, but no one has courage or energy enough to seek the cure." End quote. Be nice to someone today and know that you are loved.